Good morning. The committee will come to order. I thank everyone for joining us this morning, and I want to especially thank the witnesses who have traveled from across the country to be here with us today. On this committee, we are focused on breaking down barriers that many small businesses face, whether it is ensuring small firms have access to affordable capital or reducing regulatory burdens. Our focus on these committees to create a thriving Main Street that makes towns and communities across the country better places to live, work, and raise a family. An essential part of any community are the doctors who are relied upon in every corner of our country to keep us healthy. But what many people forget is that many doctors, especially in rural and underserved communities, are themselves small businesses. They face the same challenges that any small employer encounters: making payroll, paying rent, managing overhead expenses, while also dealing with the same regulations that larger hospitals can manage through bigger budgets and more resources. However, when doctors spend hours dealing with paperwork or cannot treat a patient because a health insurance company will not approve a treatment, the result is patients suffering. And that is why we are here today, to discuss a barrier preventing family physicians and specialists from providing critical care to their patients. Prior authorization is a cost-savings tool used to reduce healthcare spending through improper payments and unnecessary care. Before doctors can provide even routine care procedures, diagnostic tests, or prescriptions, they must first obtain approval from a patient's insurer. While in some cases this process leads to appropriate treatments, reduces costs by eliminating expensive tests or unnecessary prescriptions, it also putting an undue burden on physicians, their staff, and patients. It is not uncommon that patients now face delays of 2 weeks and sometimes over a month before getting treatment. In fact, more than 25% of doctors report that prior authorization has led to a serious adverse event for a patient in their care, and 82% report the burdens associated with prior authorization lead to delayed care. Meanwhile, doctors are sitting on hold with insurance companies to explain why their patient needs a certain treatment. Sadly, this is an issue impacting doctors practicing in nearly every area of medicine and every part of the country. It affects each doctor paid by insurance, but is especially problematic for small group and solo practitioners that simply do not have the resources to hire additional administrative staff. Between the massive student loan debt many doctors face and these administrative burdens, it is no wonder that many doctors are deterred from pursuing the great American dream to own and operate their own business. By 2030, the Association of American Medical Colleges expects the workforce shortage to expand to over 100,000 doctors nationwide. One way to combat this growing problem is to empower small private practices to fill the gaps. They can do this with common sense policies that streamline the prior authorization process, making it easier for them to do what they were trained to do: keep our communities healthy. I support reducing costs because our country spends nearly double the amount per person on health care than any other industrialized nation. Yet our population ranks near the bottom in health outcomes compared to other high-income countries. There are reasonable ways to reduce costs, such as increasing transparency in pricing so that consumers know what they are paying, allowing the government to negotiate the prices of prescription drugs so that our seniors can access affordable prescription, and increasing the use of technology. I'm excited to hear about the potential solutions to this problem so that patients can get the care they need. I look forward to hearing about how we can modernize and streamline this process so that the doctors can stop wasting time haggling with health insurance companies and continue to make the lives of patients and their families better. Again, I want to thank the witnesses for being here today, and I now yield to the ranking member, Mr. Chabot, for his opening statement.
Thank you, Madam Chair. We're here today to hear from medical professionals about the burdens experienced by small medical practices, especially utilization management. The medical field is an integral part of our everyday lives. All participants, from world-renowned surgeons to clerical and administrative staff in this field, deserve recognition for their diligent efforts to save lives. As we in Ohio know all too well, medical professionals are on the front lines fighting the opioid epidemic. In 2016, there were over 42,000 deaths due to opioid overdose. This statistic is one of the reasons prior authorization has been implemented to help those in my home state and across the nation. Methods such as step therapy and prior authorization were introduced to reduce unnecessary procedures, prevent oversubscription of dangerously addictive drugs, and reduce human error. However, despite the reasoning for these processes, more must be done to streamline communication between practices and insurance providers. Many small medical practices struggle to afford necessary staff to complete the almost 60 extra hours spent per week on administrative tasks. Doctors spend extra time on the complex processes and paperwork required for prior authorization instead of tending to their patients. Patients become frustrated, and 40% will abandon prescriptions requiring prior authorization at the pharmacy. While this may sound grim, there is still hope, and we are looking for solutions. Increased collaboration between private insurers and organizations like the AMA can ensure prior authorization requests are based on sound medical science. I want to thank the witnesses for sharing their experiences with here, if we ever stop talking. I look forward to discussing solutions to reduce the burdens on small providers and ensure a more efficient healthcare system. And Madam Chairwoman, I appreciate you holding this hearing. I think this is one of the more important hearings that we've had this year. So thank you for doing that, and thank the witnesses for coming today.
Thank you, Mr. Chabot. The gentleman yields back, and if committee members have an opening statement prepared, we will ask that they be submitted for the record. I would like to just take a minute to explain the timing rules. Each witness gets 5 minutes to testify, and the members get 5 minutes for questioning. There is a lighting system to assist you. The green light will be on when you begin, and the yellow light comes on when you have 1 minute remaining. The red light comes on when you are out of time, and we ask that you stay within that time frame to the best of your ability. I would now like to introduce our witnesses. Our first witness is Dr. Paul Harari. Dr. Harari is the Jack Fowler Professor and Chairman of the Department of Human Oncology at the University of Wisconsin School of Medicine and Public Health. He joined the faculty at the University of Wisconsin in 1990 and became an endowed professor in 2003 and the department chairman in 2007. His clinical and laboratory research focuses primarily on treatment advances for head and neck cancer patients. Thank you, Dr. Harari, for being here today. Our second witness is Dr. David Waliga. Dr. Waliga is currently the chief of the Division of Pain Medicine at Northwestern Medicine and the vice chair of the Department of Anesthesiology at Northwestern University Feinberg School of Medicine in Chicago, where he has been a faculty member since 2003. He earned his medical doctorate from Wayne State University in Detroit in 1993 and completed an internship in internal medicine and a residency in Northwestern University. He is a dedicated medical educator and holds the rank of associate professor at Northwestern University, where he has published numerous manuscripts and books chapters on pain-related topics and has lectured nationally and international. Thank you, Dr. Waliga, for being here this morning. Our third witness is Dr. John Cullen, a family physician in Valdez, Alaska, and the president of the American Academy of Family Physicians, which represents 134,600 physicians and medical students nationwide. Dr. Cullen earned his Bachelor of Science in Molecular and Cell Biology from the University of California, San Diego. He earned his medical degree from the University of Arizona College of Medicine, Tucson. Thank you, Dr. Cullen, for being here this morning. And now I yield to our ranking member, Mr. Chabot, to introduce our final witness.
Madam Chairwoman, our final witness is Dr. Howard Rogers, testifying on behalf of the American Academy of Dermatology. Dr. Rogers is a graduate of Harvard University and holds both an MD and PhD from Washington University School of Medicine. And Dr. Rogers completed a fellowship in my congressional district at the University of Cincinnati Hospital. He now owns a private dermatological practice in Connecticut, where he has treated approximately 35,000 cases of skin cancer in the last 19 years. We welcome you here, Dr. Rogers, and thank you for testifying today. Thanks.
Thank you, Mr. Shabbat. Dr. Harari, you are now recognized for 5 minutes.
Chairwoman Velasquez, Ranking Member Shabbat, and esteemed members of the Small Business Committee, thank you very much for the opportunity to testify before you today on barriers to health care and burdens on physicians. I'm testifying on behalf of the American Society of Radiation Oncology, ASTRO. I serve as the chairman of ASTRO's board of directors and professor and chairman of radiation oncology at the University of Wisconsin. ASTRO represents more than 10,000 members who strive to give cancer patients the best possible care to advance the science of oncology. ASTRO's membership includes radiation oncologists, nurses, biologists, medical physicists, and other healthcare professionals who specialize in treating cancer patients with radiation therapy. Our members work in hospitals, academic research institutions, private practices, and this year more than 1.7 million people will be diagnosed with cancer in the U.S., and roughly 1 million of these will receive radiation therapy. Today, I wish to share with you a major problem that you have identified today, this one also facing the field of radiation oncology, prior authorization. While the system may have been designed as a path to streamline healthcare, in fact, it is frequently harmful to cancer patients in receiving treatment. There are 3 issues I would like to highlight today. First, prior authorization wastes precious time that physicians could be devoting to patient care. Second, delays in cancer care can have negative impacts on patient outcomes. And third, this disproportionately impacts providers in small community practice settings. Prior authorization has become an overly bureaucratic process that requires physicians to obtain approval from health insurance companies to prescribe a specific treatment, procedure, or medication. Radiation oncologists are increasingly restricted from exercising their clinical judgment in the best interest of their patients. Instead, insurance companies and third-party payers are making clinical decisions for these cancer patients. Who would you want to make cancer care decisions for you? Your insurance company or your cancer physician? In a recent ASTRO survey, 9 of 10 radiation oncologists reported patient treatment delays due to the prior authorization process. In cancer care, timely treatment matters. Yet prior authorization practices are delaying patients from receiving life-saving therapies, literally putting the lives of millions of people at risk. In my own practice at the University of Wisconsin Comprehensive Cancer Center, we have 16 busy radiation oncologists who routinely face treatment delays for their patients related to prior authorization. Let me provide a personal example. When a prior authorization is denied, despite the best efforts of my administrative staff and resident physicians, I may be called upon to conduct a peer-to-peer review by phone. This occurred for a patient of mine with a complex base of skull tumor. The peer reviewer was a thoughtful general practitioner who was unfamiliar with base of skull chordoma and unfamiliar with radiation, and asked me for several minutes about the tumor, the natural history, the anatomy, the normal structures nearby, and before concluding, said, "Dr. Harari, you are obviously highly expert in this area. I will authorize the radiation treatment just as you prescribe." Meanwhile, my patient had been anxiously waiting for 8 days while that tumor was growing to learn confirmation that they could receive the prescribed cancer treatment that was recommended. The problems associated with prior authorization are so pervasive that 2/3 of radiation oncologists surveyed have had to hire new staff to handle these requests. In an era of value-based care, Where is the value when we're increasing cost to deliver care without any added clinical benefit? The issue of prior authorization is concerning for patients who receive treatment at private practices, who often have less staff to handle these requests. In 2018, a report from the Office of the Inspector General stated that Medicare Advantage organizations may have an incentive to deny pre-authorization of services in order to increase profits. In the same report, it was revealed that CMS had acknowledged widespread and persistent performance problems related to inappropriate denials of care and payment. In conclusion, legislation is needed to relieve radiation oncology patients and physicians of the burden from restrictive prior authorization. Members of this body can put themselves in the shoes of a newly diagnosed cancer patient to appreciate the significantly negative impact that treatment delays can have on their lives. ASTRO looks forward to working with policymakers and stakeholders to develop policy-based solutions to fix this broken system. Thank you very much.
Thank you, Dr. Harari. Dr. Waliga, you are now recognized for 5 minutes.
Chairwoman Velasquez, Ranking Member Shabbat, and members of the committee, thank you for the opportunity to testify before the House Committee on Small Business today. I offer this testimony on behalf of the American Society of Anesthesiologists and my colleagues who practice pain medicine. Physicians like me are all too familiar with the burdens of prior authorization and the toll it takes on our patients and our medical practices. Because of our current broken insurance system, physician time and practice resources are increasingly allocated to fighting insurers instead of caring for patients. It's a system built to fail. Presently in medicine, we're facing dual crises. First, we have the opioid epidemic. Second is the crisis of chronic pain. The most recent statistics on the prevalence of chronic pain conditions in the United States is staggering. I'd like to tell you about a patient of mine, who I will call Betsy, to illustrate the complicated interaction of these dual crises and the predicament many pain specialists like me encounter daily. Betsy is 38. She came to me with a 10-year history of back pain and nerve pain in her legs following a failed spine fusion surgery. When I saw her, she was dependent on high doses of opioids to manage her pain, and despite these high doses, her pain was not under control. She felt hopeless. She'd seen multiple doctors, and the cycle of this pain had been going on for years. That day in my office, she tearfully pleaded, "Is there anything you can do for me?" After examining her, I knew Betsy would be an ideal candidate for a non-opioid treatment for chronic pain called spinal cord stimulation, or SCS. This is a treatment in which we surgically place small stimulating electrodes adjacent to the spinal cord to deliver imperceptible electrical impulses to the spinal cord to block pain signals from being transmitted to the brain. To make sure this treatment would be effective for Betsy, I recommended that she taper her opioids by at least 50% before we would proceed with treatment, as high doses of opioids can cloud the effects of stimulation. Surprisingly, that day, she tapered completely off of all of her medications. Per standard practice, I first implanted a temporary spinal cord stimulating system for a 10-day trial. Her health insurance provider did approve this. During the trial, we want to see at least a 50% reduction in a patient's pain with a commensurate improvement in their physical function. In Betsy's case, the gains with her temporary trial were nothing less than astounding. She became a completely different person. Her face had brightened. She moved around my office with ease. I heard her laugh for the first time. She told me that during the trial, she went for walks around the neighborhood with her husband, something she hadn't been doing for years. She was able to play with her 2 children who have special needs. For those 10 days, she had her life back, and she was ecstatic. So I submitted the required forms and letters of medical necessity to her insurer to obtain authorization to implant a permanent spinal cord stimulation system. That implant was denied by her insurer. I appealed the denial, which was denied again. I appealed again and requested a peer-to-peer review. The concept behind the peer-to-peer review is that another physician chosen by the insurer objectively reviews the medical necessity of a proposed treatment and speaks directly to me, the provider. Unfortunately, peer-to-peer is a misnomer, as the physician reviewer, as previously stated, is usually not a similarly trained or experienced specialist in the field. In fact, I've had a general pediatrician review prior cases like this one. In Betsy's case, the appeals process took 8.5 months. Feeling hopeless and experiencing intolerable levels of pain again after the temporary system was removed, Betsy went back on opioids to control her pain. She lost hope all over again, even though we had a proven treatment that was effective for her. It was my appeal to the medical director to her insurance company that got the treatment finally approved. Today, Betsy has her spinal cord stimulator. She's not taking opioids. She's taking care of her kids. She's independent, and she's returning to the workforce. She has her life back. Betsy's ultimate clinical outcome is the reason I became a physician, to help patients live their best lives despite an underlying medical condition. Physicians don't have the resources to fight this type of fight for every single patient, not in our current practice environment. These appeals take precious time away from providing care that other patients need. And for these reasons, I'm appreciative that the committee is looking critically at this issue. In my submitted written testimony, I've included specific recommendations to remove barriers to comprehensive multidisciplinary pain care, as well as substance use disorder treatment. And I thank you for your consideration this morning.
Thank you, Dr. Waliga. Dr. Cullen, you are now recognized for 5 minutes.
Chairman Velasquez, Ranking Member Shabbat, and members of the committee, I am honored to be here today representing the 134,600 members of the American Academy of Family Physicians. I'm a practicing family physician in Valdez, Alaska, a community of about 4,000 people. I'm also a small business owner and a partner of the Valdez Medical Clinic, LLC. And along with 5 family physician colleagues, we are the sole providers for a geographically isolated community 300 miles from the nearest tertiary care hospital, and the area we serve is about the size of Ohio. The AFP welcomes this hearing on utilization management as an important and necessary step towards reducing both barriers to care for patients and the administrative burdens for family physicians. As I detail in the written testimony, family physicians and their patients face a daunting array of administrative barriers to appropriate and necessary medical care. The result has been chaos in caring for our patients, burnout for family physicians, and worse outcomes for patients. Ask any practicing family physician about pre-authorization and you're going to get an earful. Prior authorization is a major reason that small practices like mine are closing. In my own practice, a patient of mine had a combination of Crohn's disease and severe arthritis or psoriasis, and we eventually controlled both disorders with a monoclonal antibody therapy after years of trying multiple other regimens and with consultation with multiple specialists. After 2 years, we had to reauthorize this medication, which had been working so well, and that resulted in a delay of months, and during which her condition worsened. And then when we finally were able to get her back on the medication, she had a serum sickness reaction and suffered anaphylactic shock. We almost lost her. And she can now never use this medication that was working so well. Most family physicians in private practice have contractual relationships with 7 or more insurance companies, including Medicare and Medicaid. And now our practice, and again, I'm in a town of 4,000 people, has 35 different insurance plans we deal with, each of which has its own system of prior authorization and drug formularies, and which change on a regular basis. I often don't know in advance which medications and which class will be covered. And this often means that when I write a prescription, my patient has to take it to the pharmacy to find out if it is covered. And if it's not, then I need to find an alternative, often by writing a new prescription, and the process gets repeated. We use electronic pre-authorization, but we don't often get a timely answer, and this leads to a phone call by me or one of my staff to a reviewer who often has a very hazy idea about the difference between generic and trade names or even what the medication does. My patients rarely blame their insurance company for this administrivia. They blame me for not getting them the medications they need, yell at my staff, or just stop taking the medications they need to prevent hospitalization. And this is the hidden cost of prior authorization. My staff burn out and quit because of the frustration inherent in this crazy system, compounded by being yelled at by patients for not having their medications. So I was just told before I came here that my nursing supervisor is quitting next month. She and one of my MAs are spending their entire time just doing prior authorizations. And that's not what she trained for. In a recent 2019 AFP survey, administrative burden was by far the top issue facing family physicians, of which EMRs and prior authorizations for medications, durable medical equipment, and procedures such as imaging were the most impactful. Prior authorization for durable medical equipment typically requires a physician to fill out a paper form or submit specific data for approval, and each DME company has different data requirements for submission. We are being pelted with DME forms. Family physicians simply want to be able to prescribe efficiently and effectively what their patients need to help them manage their condition in a way that maintains their health. And we know how to fix it. America's frontline physicians have developed joint principles on reducing administrative burden in healthcare. The AFP strongly urges the adoption of the prior authorization and step therapy recommendations that we shared in our written testimony. We call for prior authorizations to be minimized, standardized, and universally electronic to promote efficiency and reduce administrative burdens that direct valuable resources away from patient care and can inadvertently lead to negative patient outcomes. We support the Improving Seniors' Timely Access to Care Act, that's H.R. 3107, and it's a bipartisan effort, and it's a step in the right direction, and will protect Medicare Advantage patients by streamlining prior authorization practices. The prior authorization process is out of control. It is increasing, and rather than a tool for preventing unnecessary or expensive care, prior authorizations negatively impact my patients' health and is a significant cause for family physician burnout and the closure of small private practices. And so thank you very much for your interest in reducing both barriers to care for patients and administrative burdens on family physicians.
Thank you, Dr. Collin. Dr. Rogers, you are now recognized for 5 minutes.
Thank you, Chairwoman Velasquez, Ranking Member Shabbat, and members of the Small Business Committee for the opportunity to speak before you today on behalf of the American Academy of Dermatology Association. I'm Dr. Howard Rogers, board-certified dermatologist, and I own a small private practice, Advanced Dermatology in Connecticut. As a small business owner, I appreciate the committee's efforts to prioritize reducing administrative burden, such as utilization management processes. My testimony will focus on how increasing administrative burdens are impacting small medical practices, such as my business, and more importantly, I'll highlight how prior authorizations delay necessary care for patients. Physicians' practices are on the front lines of healthcare, the healthcare system. Right now, while our country is grappling with how to increase patient access to high-quality care while reducing costs, my colleagues and I are forced to comply with utilization management systems that seem designed to force doctors out of practice. I and other physicians in my practice dedicate at least 15 hours a week on prior authorizations alone. Prior auths drive up the cost of running a medical practice. They routinely delay critical patient care and contribute to physician burnout while providing no increase in quality of care. So dermatologists diagnose and treat more than 3,000 diseases. For many skin diseases and conditions, the medications are specialized and their use is highly nuanced, and it's dependent on numerous factors specific to the patient and his or her disease. Prior authorization policies place a third party in the decision-making position with little or no understanding of the complexity or full history of a patient's condition. So just imagine seeing a patient in your office with a severely painful condition or a rapidly spreading infection. You prescribe a highly effective medication, you walk the patient through how they're going to use that medication, and you assure the patient that they're going to soon feel better. Then the following scenario occurs. The prescription is denied because prior authorization is required, and you try for days or weeks to get that medication approved while the patient continues to suffer. The patient goes to the pharmacy repeatedly and is told that the medication is denied, is no longer covered, requires a prior authorization, and there's nothing they can do about it. You can imagine the frustration and desperation of patients when they're at their most vulnerable. So in my office, my staff spends 70 hours a week, 70 hours a week on prior auths alone. I've had to hire 2 full-time staff at the cost of $120,000 a year with salary and benefits to handle the volume of prior auths. These funds could definitely be better spent on staff education, improved benefit packages for staff, new medical equipment, technology, all those things that bring us forward as physicians. We appreciate Congress working to help alleviate the prior authorization burdens by including language to create a standardized electronic prior authorization form for Medicare prescription drugs. in the Support for Patients and Communities Act, which passed in October of 2018. Prior authorizations are also delaying patient access to necessary dermatologic procedures. So Mohs micrographic surgery is a technique that dermatologists use to surgically excise skin cancers, ensuring in real time that the malignancy is fully treated while sparing as much healthy tissue as possible. Typically, Mohs surgery does not require a prior auth. However, the reconstruction of the defect left after the surgical excision does. And since the physician doesn't know the extent of the repair procedure that will be needed prior to the surgery, obtaining the prior authorization is not possible. And so this leaves the physician, me, with a patient with a hole in their skin and no authorization to repair it. By prohibiting plans from requiring prior authorizations during skin cancer surgery, patients would be ensured the best chance of positive outcome. To address this burden, we ask the members of the committee to support the Improving Seniors Timely Access Care Act, H.R. 3107. This legislation aims to relieve prior authorization burden for procedures under Medicare Advantage plans, as well as to provide transparency to patients and providers. So it's impossible for me to capture in these remarks how the prior authorization process hinders the practice of medicine. Even with the extra support staff, the providers in my practice are regularly disrupted from patient care to deal with prior auths. In fact, 1/4 of all communications in my office, be it phone calls, faxes, emails, EMR notifications, payer portals, they're all associated with prior authorizations. And the kicker is that most of my patients' prescriptions and repairs eventually get approved, but only after exhaustive efforts of calling insurance and appealing denials. However, the process truly wears down my colleagues and staff to the point where I worry about burnout for them. We became physicians to help patients, not complete paperwork. And the constant struggle has become too much for many of my colleagues, including my practice partner who's retiring despite being in good health and loving seeing his patients. Prior authorization ultimately ends up costing the healthcare system more than it saves. So on behalf of the American Academy of Dermatology Association, I thank you for holding this hearing and your interest in safeguarding physicians and patients from unnecessary utilization management practices. And I'm happy to answer any questions.
Thank you, Dr. Rogers. And let me just take this opportunity to thank all of you for your insightful testimonies, but also putting a face into the issue of a human face into the issue of prior authorization. I just would like to ask each one of you, how often do you have to delay the start of treatment because of the prior authorization process?
Chairwoman, the survey that ASTRO conducted of all radiation oncologists recently identified that 9 in 10 radiation oncologists have patients with treatment delays. As many as 2/3 of patients will experience a delay in the start of their cancer treatment related to prior authorization.
Yes.
And I guess I'm speaking just from a personal perspective, but we have at least 3 or 4 a day, if not more. Just in the patients that I'm seeing.
So, in your view, are these health insurance company that you have to deal with equipped to determine the course of action or the course of treatment that is best for your patients?
I'd like to answer that.
If there has been any study conducted to that effect.
Oh, as far as studies, I don't know, but as I think we all commented, the individuals who are ultimately making the decision about our patient's fate and how their health care will be directed is made by someone who does not do what we do. They don't see the patient. They probably have not looked at the medical records that we've sent to them repeatedly, and they often don't know the latest technology that we're applying in these cases of treatment.
So are you telling me that you don't know what type of data or scientific evidence the health insurance companies are using when making a decision?
I can tell you that there is very strong, robust scientific data that delaying cancer treatment can decrease survival. There are dozens of papers identifying each week of delay for fast-growing tumors can knock off 1 or 2 or 3% of the cure rate. I'm aware of no scientific data that the insurance companies provide as to why those delays are acceptable.
So in a 2018 report, and I believe that some of you mentioned it, the OIG stated that, and I quote, Medicare Advantage organizations may have an incentive to deny pre-authorization of services in order to increase profits, end of quote. To the entire panel, based on your experience, do you find this to be true? In other words, is this cost-saving measure used by insurers really a disguise that allows them to increase their profits at the expense of patients and at the expense of, the bottom line of your practices?
I'm sorry to say that I think that this is true. This is certainly the experience of the radiation oncologists across the U.S. that were surveyed, identifying that 2/3 of the prior authorization denials were subsequently overturned on appeal, suggesting that the incentives that are derived by healthcare benefit managers may be prioritizing their actions over what is best for the individual cancer patient.
Yes, Dr. Cullen.
So I think for us, one of the best examples is albuterol. Albuterol is an inhaler used for asthma. But I have to decide whether the insurance company will accept albuterol or whether they'll accept ProAir or whether they'll accept Ventolin. They're all the same thing. But it really depends on which one that insurance company will accept at that moment in time. And a lot of that is based on agreements that they have with pharmacy benefit managers. Another good example is we start joking about the PPI du jour, that is the proton pump inhibitor of the day, because those change on a regular basis. We're never informed about what those changes are. But these are common medications. I was talking earlier that I had to pre-authorize hydrochlorothiazide, which is a blood pressure medication. It's been used forever and has a great safety track record. It's very inexpensive, but I had to prior authorize even that medication as a generic. So unfortunately, I think that is the case.
Dr. Rogers.
Yeah, unfortunately, there's little or no transparency in how the prior authorizations are judged, nor the guidelines by which the reviewers look at the clinical information provided. It seems haphazard, and it's designed to wear the physician down to the point where care isn't rendered, which would definitely increase profitability for insurers.
So I don't have much time left, but I just would like to ask the following question and see which one of you would like to answer. Do the third-party benefit management companies' Medicare Advantage plans hired to conduct prior authorization also have this perverse incentive?
I believe so, because it is reflected in the overwhelming number of prior authorization denials that are then subsequently overturned after 2 to 3 weeks of fussing back and forth.
I ran out of time, so thank you so very much. And now I recognize the ranking member, Mr. Shabbat.
Thank you, Madam Chair. Dr. Rogers, I'll go with you first. In your opening statement, you mentioned that not being able to complete surgery for the patient because of prior authorization. Could you explain how, on an everyday basis, this actually works in the office, and what specifically about prior authorization hinders the process? Just how does it make it that much more complicated than everything else?
Sure, I'd love to give you an example. So just a few days ago, I was operating on a patient, and unexpectedly, the skin cancer that was on her nose extended all the way through from the outside to the inside, resulting in a full-thickness defect. In that sort of scenario, the reconstructive codes that are going to need to be used are extensive. And so I immediately asked my nurse, get on the phone to her Medicare Advantage and get prior authorization. So after an hour of being on the phone, the nurse said they're going to get back to us in a few days. But I have a woman who, if I don't properly reconstruct this nose, it's going to collapse. She's not going to be able to breathe properly, and the cosmetics of it will be severely affected. So in that sort of scenario, I go ahead and perform the reconstruction, including cartilage grafting and flap reconstructions, with the distinct possibility that there will be no payment on the end.
Thank you very much, Doctor. Dr. Cullen, many states have recently passed laws on step therapy protocols that would benefit doctors, patients, and insurers. Do you think these legislative efforts can improve some of the burdens that you've described with prior authorizations?
I think specifically reducing the amount of time to get a response, those kinds of legislation have been shown to be valuable. I unfortunately have not been able to experience any of these personally because Alaska has not done either one of those as far as step therapy or timeliness in response. We would like to see the step therapy, though, drastically reduced as an academy because we don't see that as being a valuable way to pursue this.
Okay. Thank you very much, Doctor. Dr. Waliga, according to CDA data, most opioids are not prescribed by physicians such as yourself, but rather primary care physicians or dentists. Are prior authorization requirements for opioids worth the extra time it takes if it helps keep addictive medications at bay?
First of all, I'd like to mention that the number of opioid prescriptions in the United States is going down, and the number of deaths related to prescribed opioids has also precipitously dropped. The deaths that we're seeing is primarily from recreational use, basically street drugs, heroin, and fentanyl. As far as the pathway of primary care physicians writing for opioids as well, I think we've made tremendous gains in educating providers, primary care providers, as well as ancillary providers with regard to not going to opioids first, and if opioids are going to be prescribed, having much more tight guidelines, practice guidelines around that, urine drug screening on a regular basis if the prescribing will continue, having the patient read and sign and agree to an opioid agreement which states the prescriber will be the only prescriber. The patient will take the medication as prescribed, not run out early, not double the dose, not treat themselves without the provider's input. So that problem, I think, is decreasing. We still do see the CDC guidelines on opioid prescribing misappropriated or misapplied, wherein here's a CDC rule that says don't prescribe more than X amount of drug per day to all patients, and that's misapplied. We've had patients who've done very well on doses of opioids higher than that, doing well, showing no signs of substance use disorder, and that medication is being denied at times.
Thank you, Doctor. I appreciate it. I wanted to get one to Dr. Harari real quickly. Doctor, Cincinnati Children's Hospital in my congressional district helps community practices with their billing and software needs. Do you know of any other hospital systems that do this?
There certainly are. We have at the University of Wisconsin, and I'm sure similar in your state, as a major academic center where we have satellite outreach clinics in community practice settings where we provide the radiation oncologist and physics technical care, and we will assist them with the billing process in those community practices.
Thank you very much. And I would note Cincinnati Children's Hospital is usually in the top 3 best children's hospitals in the country. And when you consider the size of Cincinnati versus some other areas, we're very proud of Cincinnati Children's Hospital. So thank you very much.
The gentleman yields back, and now we recognize the gentle lady from Kansas, Ms. Davids, for 5 minutes.
Thank you, Madam Chair. I appreciate the opportunity for us to discuss this very important topic today. I definitely am determined to do everything I can during my time here in Congress to increase patients' access to health care. I'm very, very concerned about the prior authorization and step therapy being used as barriers to that access. I've heard from a lot of providers in the Kansas 3rd District, which I represent, providers and physicians, and they're frustrated, they're disheartened by the way that prior authorization and step therapy are used to delay care. And I know some similar sentiments have been shared here today. I was recently able to take a tour of a pediatric orthopedic practice in Prairie Village, Kansas, and learned about the burden of step therapy in their practice. For that small business, fighting for a single step therapy protocol exemption or appeal costs their nursing staff sometimes 1 or 2 full hours, as different insurance providers use different and often complex processes. That kind of arduous paperwork is... The arduous paperwork just to provide the right care to patients imposes increased administrative costs, which I'm sure you're familiar with, and just the time to the medical practice. I guess the first question I would ask is, prior authorization and step therapy are intended to be processes that encourage providers and insurers to seek the most cost-effective treatments and procedures. Do you think those processes generally reduce out-of-pocket costs for patients? And I'll just open it up because I'm sure everybody on the panel probably has thoughts on that.
I don't think that it does. I mean, first off, I think that if we just had a transparency of what the drug costs were, the actual costs, that we would do more to reduce costs for our patients than any other factor. Because as family physicians, that's what we try to do, is we try to reduce the burden for our patients, kind of regardless. What I have seen, though, is that the costs really have risen as we have been engaged in this whole process of prior authorization and step therapy. And so it really does not seem to be doing its intended purpose, if that ever was its intended purpose. But like I said, I think that just having a transparency of what things actually cost is going to do more than anything else.
From the dermatology perspective, I can tell you that in many circumstances, the cost of the patient is grossly higher. And I'll just use an example of what's called a topical calcineurin inhibitor, which is a type of cream that is non-steroid and has no side effects associated with the skin. And a lot of insurers are requiring 2 failures of steroid medication, which may be contraindicated to sensitive areas like groin, face, things like that, before you can get coverage of the medication that's going to work with the least side effects. And so the patient has multiple copays before they actually get what they need.
I also think there are cases in which the steps of the step therapy really don't make sense for the patient, and it wastes valuable time and money. I think in cases, particularly with specialists, I'm probably biased, but by the time the patient gets to a medical specialist, many of the simple things have failed. And our judgment, I think, is quite important, and in some cases we should be deferred to, and we're not.
Well, one, I appreciate that, and Dr. Cullen, I would just say, I think you hit the nail on the head when you said if it was the intended purpose. I'll leave it at that. I appreciate your time, your testimony, and the work that you all are doing. And with that, I yield back.
The gentle lady yields back, and now we recognize the gentleman from Minnesota, Mr. Hagedorn, for 5 minutes.
Thank you, Madam Chair. Thanks to the witnesses. Yeah, I would agree. You go out and do all this education, training, put years and years at work to prepare to treat patients, and then you go to do the work and you have to ask permission every step of the way, and people are looking over your back and questioning you, and then sometimes changing basic decisions that you make as to how best to treat patients. And so whatever we can do in order to make it possible for you to do your job, we'll support you 100%. I think we'll support that bill that you're talking about with the Safe Step Act, and also, but isn't this part of a kind of a scam that's going on with these pharmaceutical benefit manager programs where you'll prescribe a drug and there may be like 2 competing drugs do the same thing, and when it comes time to fill it at the pharmacy, there's these rebates and things that they get back. The money doesn't go to the patient, doesn't go to the consumer, certainly doesn't go to you. And they're picking winners and losers as to which drugs to use based on basically kickbacks. They jack up the price of the drug in many instances in order to make that that happened. I mean, are you familiar with this? You see this in your practice? I'll leave it to anybody. You don't have to use my language on it. I'm pretty tough. You know what I'm talking about, though. Right?
I think that I'm going to defer to your expertise on this.
Well, we spent some time during the break with a local pharmacy, and they walked us through it, and it's pretty rough what happens, and it's not helping the consumer, and it's not helping the patient necessarily, but they're deciding based upon what works best for them financially, which of the drugs to prescribe. And in the olden days, doctors would talk with pharmaceutical companies and others, get the idea. Now you can't hardly have any of those conversations. You can't take a pen. They've wiped you out of that, which is fine, I guess. But there's this kind of middleman that's doing that job now, and I'd like to see some reforms there. If you don't want to address it, maybe it's too sensitive, but we'll move on from there. The other thing I'd say is this isn't just a problem that you have with private insurance companies, right? Don't you deal with the government a little bit and have some of the same issues? I think there's some things that we can do to streamline that with Medicare, Medicaid. I'll start over here.
Absolutely. This is pervasive, and I think your words that this is not benefiting the patient is very precious. There is no benefit to a cancer patient to have a delay in the start of their treatment. And even when there is the intent to be sure that an effective therapy is being delivered, often by pushing the physician to generate a less expensive therapy that comes with collateral damage in the name of radiation, where a simple plan to treat a brain tumor where the beam has to go through the eye and cause damage to normal tissue, or go through the heart to treat a lung cancer, because they want to see a simple plan, just front and back radiation rather than a conformal plan. Less expensive, but more damage to the normal tissue for the patient. And so in terms of cost, ultimately this costs the healthcare house of medicine much more to deal with those side effects. So this happens on all sides.
On a more practical level, I know that my Medicaid patients and the Medicare Advantage patients are scheduled 15 business days after their evaluation with me when I've put forth a treatment plan, because we know it's going to take at least that long to get that approved. So 15 business days is 3 weeks. That's a long time to wait for treatment when you have pain that's described as 10 out of 10.
That's not good.
We actually have fewer problems with Medicaid and Medicare than with a lot of the private insurers. This is a process that is going across the board, but I guess in answer to your previous comment, the big problem we're having is that the formularies are changing on a regular basis, and that's because of things other than patient care. And so that is something that we're dealing with. It's creating just tremendous chaos in our ability to prescribe for our patients, and it's causing chaos for the patients because a lot of times they've been on medications for years, and all of a sudden we have to come up with something else. And even if we change the dosage, we have to come up with another prior authorization plan. It has absolutely gotten out of control. So in the light of that, actually, the Medicaid and Medicare are actually doing better than the others.
Congressman, I agree with you entirely in that government plans are a problem in addition to private insurers. At least in my state, the kind of most egregious delays in care and not getting back to our office of whether a prescription is approved or denied is with the state Medicaid.
Thank you very much. Chair, thank you.
The gentleman yields back, and now we recognize the gentleman from Pennsylvania, Vice Chair of the committee, Mr. Evans.
Thank you, Madam Chair. I thank you, Madam Chair, and the ranking member for this hearing. This is very appropriate during this time. Dr. Cullinan, according to your testimony, primary care physicians spend nearly 50% of their time on administrative activities, such as prior authorization, and only 20% of their time on clinical activities. Do these burdensome administrative tasks limit the number of patient primary care physicians can accept and treat?
Indeed. So I've been in practice for 25 years. Before all this started, I would see about 25 patients a day. I am now down to about 15 patients a day. This has reduced the number of patients that I've been seeing. That's a problem because we're looking at a severe shortage of primary care physicians in this country, and what I'm experiencing is being replicated across the country.
Can you explain the role in that particular case of primary care or family physicians in the patient overall health care?
So one of the reasons why our healthcare system is as expensive as it is that we do not prioritize primary care to the extent that we should. We're spending about 4% of our dollars on primary care. Other healthcare systems that are spending a lot less money on healthcare than we are have upwards of 15 to 20% of their dollars spent on primary care. The problem is that things that are not caught in a timely fashion, or that the chronic diseases that end up in hospitalizations, if you don't have family physicians and primary care physicians managing those, you end up spending a lot more money. So for every dollar spent on especially advanced primary care, you save about $13 overall to the healthcare system as a whole. One of the reasons why we are spending as much as we are, 18% of our GDP on healthcare, is because we are not prioritizing primary care.
Can anyone else on the panel, that same question I asked, explain the role of primary care, family physicians, and patients give some reaction to that? Any other comments on it? Yes.
I agree with the incredible importance of having ready access to primary care with a huge variety of different treatments that they can do in disease processes. As a small specialist, I also see the value of specialty care in that there is more advances in medicine every year than has ever been in the past of medicine. And so in order to provide patients with the most up-to-date care, we need an integrated system that allows primary and specialty care to interact and collaborate efficiently.
I would also add that we've discussed the shortage of primary care physicians. That trend is continuing. When medical students finish medical school and they go through their training, they often have $100,000, $200,000, $300,000 worth of debt. I can't imagine that one would be able to pay off that debt in a timely way if you're seeing 12 to 15 patients a day in a family practice. It just doesn't make any economic sense at all. So that trend will continue.
There's a reason that many of the U.S. medical schools are emphasizing primary care to their medical students. At the University of Wisconsin, we're one of two schools of medicine and public health that is trying to serve the needs of the state in rural areas of Wisconsin. Many states have this issue where the cities are well served with primary care, but the rural communities are not. And so, as Dr. Cullen alluded to, we have to make a much more concerted effort to provide talented primary care providers to our citizens.
Madam Chair, yield back the balance of my time.
Gentleman yields back. And we recognize the gentleman from Pennsylvania, Dr. Joyce, ranking member of the Subcommittee on Rural Development, Agriculture, Entrepreneurship, and Trade, for 5 minutes.
Thank you, Madam Chairwoman. Today I have with me a letter signed by 371 national and state-based patient, provider, and other healthcare stakeholder groups in support of H.R. 3107, the Improving Seniors Timely Access to Care Act, which would bring the needed transparency and accountability to prior authorization in the Medicare Advantage program. I respectfully ask that the letter be submitted for the record.
Without objection, so order.
Thank you, Madam Chair. First of all, I look out at this esteemed group, and with bias, I say it's the most intelligent group that has presented to our committee so far.
We've got a lot of intelligent people.
Thank you, Ranking Member Mr. Shabbat. I've worked closely with radiation oncologists. I have friends I've utilized anesthesiologists with backgrounds in pain management. And daily, until just 8 months ago, I would interact with family practitioners who are the heart and soul of American medical care. And of course, when I look at Dr. Rogers, I see a compadre, a board-certified dermatologist, a fellow in the American Academy of Dermatology. We share so much. I hear your story, and I thank each and every one of you for bringing it to the halls of Congress. It is so important for us to realize what you go through on a daily basis for, as you said, Dr. Cullen, to make people's lives better. Seems like a simple goal. And yet there are obstacles that are being placed in front of you. And we need to hear and work hard to repair those obstacles that are in front of you. So please allow me, if I can address the first question to Dr. Rogers for being here today. Dr. Rogers has an interesting expertise that I'd like to illuminate and tell everyone on the committee what he does. He's a board-certified dermatologist, as he said, that takes care of over 3,000 diseases, skin diseases, and diseases that affect all organ systems in the body. In addition to that, he did additional training in Cincinnati with Dr. Brett Coldiron in Mohs micrographic surgery, which is a long name for a type of surgical training that allows the dermatologist to remove the skin cancer and see that the margins are clear and then repair it. So it seems like a simple process. He talked about treating a patient with a skin cancer on their nose, and arduously he removed that skin cancer until there was no sign of it left behind. And then he went to repair that, and he couldn't have the authorization to do that repair. This is a tragedy. This does not allow for good patient care. So what does that mean? That means that the patient's going to have to come back, risk adverse reactions to collapse the cartilage of their nose while he waits for the approval to do that, and go through anesthesia again, go through the injections that he's already put the patient through and is prepared to repair that. Dr. Rogers, did I summarize this case clearly?
Thank you, Congressman. You did summarize that well. As a dermatologic surgeon, it is clear to us that as we're working on the patient, there are a lot of patient-specific factors, and we can't know exactly how best to repair somebody from a functional standpoint so that they're going to breathe, have normal lip function, have normal eyelid function, as well as a great cosmetic result beforehand, which is basically what the insurer is asking for. They are asking for a prior authorization, exactly how this is going to go. And when you are in the operating room, you don't know until you're there, and then you're scrambling to try and get prior authorization to do a medically necessary procedure to put this patient back together.
In other areas, let's talk general dermatology, if I may, please. Someone comes into your office, they have a cellulitis, a skin infection of the upper extremity. And let's say from our common knowledge base that you prescribe a form of penicillin, maybe a cephalosporin that's been in the generic form since I graduated from medical school from a long time ago. And you want to prescribe cephalexin. What obstacles do you placed in front of you, Dr. Rogers?
Yeah, so this has actually become a problem this year, which is just kind of unimaginable. So the main standard of care treatment for a staph infection, superficial staph infection, is oral cephalexin. We all know if you have a staph infection, you got to jump on it right away. And there is an insurer who has placed a prior authorization on cephalexin, and I've seen 2 instances in my office where superficial infections have gotten out of control because of a prior authorization process that delayed treatment. Patient went to the pharmacy, didn't get their medicine, and then progressed rapidly and had to be hospitalized, resulting in hundreds of thousands of dollars of expense that could have been dealt with right at the pharmacy.
Thank you so much, Madam Chairwoman. I just want to start by saying I had an ear infection last week, and I went to see my primary care physician, and I got an earful, pretty much in addition to treatment for that ear infection, on exactly what each of you have testified this morning. So Thank you so much for being here. Healthcare is absolutely the number one issue that I hear about in my congressional district. My colleague from Minnesota just a moment ago talked about the cost of prescription drugs. My own experience in healthcare has been that when we have these conversations, it's a little bit like the circular firing squad. Brand name pharmaceuticals blame the PBMs blame the pharmaceutical companies, and everybody blames the health insurance companies. I'm curious, as we sit here today on a couple of issues, though, where do you think, each of you, as members of Congress, we can, beyond just the administrative burden, which is absolutely clear is an issue in our country, where else would you have those of us who just arrived in Congress focus in terms of the cost of health care, not just the cost of health insurance, but the cost of health care? And I was particularly curious, Dr. Cullen, your comments around prevention over care. And then I want to ask the specialist a couple of questions, too.
So a lot of it, I think, has to do with access and how much people are paying out of pocket, which is definitely getting worse. I had a patient recently who did not come in to be seen for an ear infection, and because of her copay, as a result, she developed just a rip-roaring otitis externa that I ended up having to put her in the hospital for. So what would have been a $65 visit and a $25 prescription of an antibiotic turned into probably a $15,000 to $20,000 hospitalization. We're doing this repeatedly, where we're saving saving up front and we're paying so much more down the road. And that's not even true with just the cost. I mean, there's a human cost too, because, for example, maternal mortality has been increased, and part of that has to do with the access for prenatal care, which is diminishing, and we're having obstetrical deserts develop in the country. Access is probably one of our biggest things. Because we don't have that access, and I would include the access to a primary care physician, that we're spending enormous amounts of money at the other end, where we could be spending a little bit in the beginning, and we could be recouping that investment enormously at the other end. I think that's probably the biggest issue, outside of the amount of administrative work. Right now, we're spending, it's 2 for 1, 2 hours of administrative time for every hour of patient care. If we cut that in half, we could see twice as many patients. I mean, this is something we definitely need to address.
I also just want to follow up with that, with Dr. Herrera. Tell me, is there any reason in your mind to justify prior authorization for CT scans when dealing with routine cancer care? It's interesting to me that is even a barrier for you.
Oh, it's interesting to us as well. I recognize that in the broad scale of medicine, imaging can benefit from care and judicious allocation of resources. But when a patient has a cancer diagnosis and they need to have high-quality imaging, be that a PET scan or a CT scan, to best, most accurately define their tumor so that surgery or radiation or chemotherapy can be most effectively delivered, it is unfortunate sometimes to have so much second-guessing of the known cancer expertise on what that imaging should be.
And where would you have us focus on driving down the cost of health care?
You mentioned, the others have mentioned the issue of prevention. Cancer prevention is an enormous area of potential benefit. The funding of the National Cancer Institute and the NIH in advancing prevention studies, the known role of tobacco and alcohol and nutritional elements that contribute to cancer. We could diminish the cancer burden in the U.S. dramatically with some steps in those areas, as opposed to waiting until there is an advanced cancer present.
Thank you. Madam Chair, I'm just about out of time, so I'll yield back.
The gentlewoman yields back, and now we recognize the gentleman from Oklahoma, Mr. Hearn, ranking member of the Subcommittee on Economic Growth, Tax, and Capital Access, for 5 minutes.
Thank you, Madam Chairwoman, ranking member, and certainly to the docs that are here to testify on real problems in medicine today. Like my colleague said, no matter where you go, you don't have to be a doctor. You can be a patient. If they know you're in Congress, you're gonna hear the issues, and so it's great to hear it firsthand. I've been a businessman for 34 years, and what we know is regulations cause problems. Certainly, when you have extraneous regulations like you all are experiencing, it's very difficult. In my world, it's Dodd-Frank and many other regulations that cause a real burden on the small business. We've heard these from many times over, and people sitting in your same position. As the ranking member said, we've had a lot of really smart people talking about regulation, regulatory problems across many industries. You know, in the small business practices, your hurdles really are about utilization management programs that, you know, are of all sizes that really create a real problem. It could be as much as pharmaceutical companies advertising on TV a better drug than you prescribe, and the patient saying, I want that drug because I saw an advertisement. We have a whole plethora of issues that we need to get after in this realm. As my colleague once again said, this is one of the #1 issues, if not the #1 issue in America today, to figure this out. And, you know, fortunately for me personally, I have a colleague that's a dear, dear friend of mine that you've already heard from that I want to yield the balance of my time. I'm a person that says, instead of some of us that just talk about and use talking points, let's let folks who are really experts in this field, and I want to yield the balance of my time to Dr. Joyce, please.
Thank you, Representative Hearn, and thank you, Madam Chair, for allowing me just to complete this. I think the message that you've brought to us today is clear, that step therapies and authorizations delay care. So I'm going to allow Dr. Rogers just to kind of shine a light on what you mentioned briefly, but I'm going to lay some background. So he talked about treating some serious skin conditions and the ability to make a decision not to use topical steroids, which have severe side effects in some situations of where you apply them. So you might not want to put a topical steroid on your face because it thins the skin. And there are other areas of the body that you might choose to use a prescription vitamin D analog. He mentioned it by its name. And yet, Dr. Rogers, I'm going to turn it back to you with the remaining time. So I send to you a 12-year-old with a type of dermatitis and inflammation of the skin that you make a decision to use a non-steroid, a topical therapy that has very few side effects to the skin, that's a vitamin D analog. What challenges do you face?
So for dermatology, pediatrics patients are, you know, they're special, all right? They have a very high amount of surface area of skin, and so you always have to worry about side effects and absorption in those patients. And so you don't necessarily go through the standard way of thinking about patients. You start with safety first because that's how I would deal with my own patients. And so when I see a patient like this, first of all, I know that I'm in for a lengthy battle. It's not the old days where you write a prescription, send them to the pharmacy, and they get what you prescribed and get better. So I come out of the room and I say, all right, we're going to start this vitamin D analog. Could you start the process? And so the prescription gets entered, and the pharmacy then gets a denial, and then they send back a number for us to call of the pharmacy benefit manager that's associated with this insurance. And then my staff spends an hour on the phone to figure out what clinical information it is that they want. Then we get some forms, fill those out, send it back. Then they send it back saying, denied, you need to go through step therapy. I write an appeal letter saying, this is a 12-year-old boy. I don't want to be placing high-potency topical steroids that are going to result in side effects in this patient. It's not standard of care. They delay for 2 weeks and then results in a denial. I write another appeal letter and get a peer-to-peer, which may or may not go through. The whole process took me an hour, and took my staff 4 hours for this denial. And the frustration level is quite extreme, actually.
And in the meantime, the patient care is delayed.
Delayed, and the patient continues to suffer needlessly.
I think that you have all come to us to shine a light on this problem, and I thank my colleague for the additional time. Madam Chair, I yield back.
Thank you. The gentleman yields back. Now we recognize the gentleman from Illinois. Mr. Schneider, for 5 minutes.
Thank you, Madam Chairman and Chairwoman, and I want to thank the witnesses. I apologize. We're oftentimes pulled in different directions, so I'm just getting here, but I had the chance to read through your testimony, so I appreciate you sharing your experiences. Dr. Relay, I'll start with you, also from Chicago. Been a patient at Northwestern, a fan of Northwestern, graduate of Northwestern. But in your testimony, you described the story of a 38-year-old patient who goes through a process. You do the first step of the test to make sure the treatment works, and then you have to go through the delays. I read that story with empathy, frustration. You can run through the list of emotions. What would the right process look like if you were just to describe it? What are the goals that we should be working to achieve in putting guardrails on the system, but making sure that you're able to do what you want to do and that the patient's able to get, in this case, the woman's able to get the treatment that she deserves?
So I know the case was fairly extreme, but I actually experienced these same similar stories every day. I think the main points of this case was a tremendous delay between when we found a proven therapy that improved profoundly this patient's quality of life, her family's quality of life, beyond expectations. 8.5 months later, requiring, going back on opioids. I think everyone in this room has been concerned about the opioid crisis, where the pendulum is swinging on opioid prescribing. We don't ever want to put a patient back on opioids if we found something better, more effective, that can be used for the patient's entire life. A shorter period between the time of the proposed therapy and the actual approval. We need to have a specialist who is similarly trained or experienced to help make the decision whether the treatment that we're proposing is medically necessary. Our role should not be to educate someone who knows absolutely nothing about the therapy or the disease process. That individual should not be in charge of deciding the patient's healthcare fate.
And to that point, Dr. Hariri, and I may be repeating myself of things said earlier, but in your written testimony, you talked about the times that you're talking to someone who is not a peer-to-peer review. And if you could elaborate that. Is it absolutely necessary to have someone who is a peer or just have someone who understands what you're talking about? Is that trainable?
No, thank you, Congressman. Ultimately, we want to have someone who has the best interest of cancer patients in mind. And repeatedly, it's apparent that that is not necessarily the case when we're going through the prior authorization process. There does appear to be a repeated denial and delay strategy, knowing that some practitioners, particularly small private community practitioners who do not have the bandwidth to hire personnel to combat the paperwork with prior authorization. We have had ASTRO members recount stories where they say, I will go ahead and deliver the slightly less optimal radiation treatment plan, knowing that then I won't have to go through a 5-hour process or recreate multiple treatment plans that are going to be denied. So ultimately, that is hurting cancer patient outcome and ultimately adding costs to the system.
Okay, and my last question, I'll ask the whole panel, and start with you, Dr. Rogers, and go across. I understand the problems with process, and I come to this as an industrial engineer, process engineer. Process matters. What about the goals of trying to make sure not just that we're getting the right care, but the right cost? Is there a problem with the goals at the very beginning, or is it strictly the process?
In a time of increasing healthcare expenditures, of course, the goal has to be to deliver cost-effective, high-quality care. Having a prior authorization process that is efficient, transparent, and workable for a small business practice would meet that goal plus the goals of running a small business.
Dr. Collin?
And I would agree with the goal, as we want high quality but a less costly system than we have currently. As far as the process, we've all gone through training for many, many years. And I think that one of the frustrations about this is the not trusting us to use our best judgment based on our education and based on our experience. We could save enormous amounts of money by just not engaging in all this activity. So I think we need to minimize the prior authorization process as much as possible. So I have two people that are doing full-time. They are doing prior authorization. They could be better served taking care of patients, doing prevention, doing education. Instead, all of our resources are really devoted to something that we have the training just to take care of.
Okay. And I'm out
The
of time.
gentleman's
I
time
yield back.
has expired. Now we recognize the gentleman from Ohio, Mr. Balderson, for 5 minutes, who is the ranking member of the Subcommittee on Innovation Workforce Development.
Thank you, Madam Chair. And thank you all, panel. Appreciate you all taking the time to be here today. I'm going to be very brief. I know that everybody's been here for quite some time, but last year, physicians, pharmacists, medical groups, hospitals, and health insurance announced their commitment to working together to improve prior authorization process for patients' medical treatments. I have a consensus here, and Madam Chair, I would like to put this in the record, please. That was done by many member organizations that most of you are associated with. And if you don't know what this is, I can most certainly give it to you. We can send you guys a copy, and so you can go over this. AMA authorized at Blue Cross Blue Shield, American Hospital Association, amongst some of the few. But in it, the healthcare leaders stated their intent to work together to streamline requirements for therapies as well as accelerate industry adoption of national electronic standards for prior authorization. What other actions could be taken to improve the challenges faced by healthcare professionals? And anybody on the panel can answer the question, Dr. Hood.
Thank you, Congressman, for bringing that forward and the comment. There are a lot of elements of the prior authorization that could be streamlined and improved. There are centers of excellence in terms of quality and value that are having 90% of their denied prior authorizations overturned on appeal. Those centers could be identified to say, there's no practice challenge here. We could spot check 1 in 10 cases for prior authorization rather than torture them through every case. There are a variety of examples like that: increased transparency, public dissemination of the utilization parameters that each insurance provider uses so that it is not a mystery to the patient and to the provider as to which regulations they are using. Often they're not using national standards in oncology. The National Comprehensive Cancer Network, 30 of the top cancer centers in the nation that create guidelines. Many of these third-party benefit manager organizations don't even adhere to those national benchmarks. So there are a number of areas of transparency that could be improved.
Thank you. That was a great answer. Would anybody else like to comment? Doctor, I can't, you're in an angle. Dr. Rogers, I apologize.
Thank you very much for that excellent question. One of the things that comes to me that could definitely improve the situation from a transparency standpoint and also from a consistency standpoint would be to have, instead of pharmacy benefit managers deciding on how best to administer prior authorizations, have the physicians who are at the point of the spear weigh in. You know, the American Academy of Dermatology would love to have a seat at the table in terms of defining what is reasonable in terms of different treatment algorithms, and would have much greater buy-in from our physicians if we could have that sort of collaborative arrangement.
We're dealing with PPMs in the state of Ohio. I'm sure you've heard.
So I think that I told the story earlier that I had to prior authorize hydrochlorothiazide, which is a generic medication. I think that all generics should not have to go through the prior authorization process. I think that's just absolutely ridiculous. And so I think that as much as we can minimize that prior authorization, I think is really important. As physicians, we really do try to do the right thing by our patients, and we're spending a lot of money just because there are a few outliers. And I think that all of us are trying to do the very best we can for our patients for the least amount of cost. And I think there needs to be some recognition that that's what we're trying to do. The part of the problem with prior authorization is assuming that that physicians are only in it for other reasons, and that's just not the way it really is. And so I think that I'd like to see all of that whole process minimized. For those practices that are involved in quality-based payment contracts, there's really no reason to have prior authorization at all. And that is with alternative payment methodologies, not for fee-for-service. We're actually getting paid by the quality we deliver. And so there should be no prior authorization for those practices.
Would you like to add, or you think that everybody's fulfilled? Thank you very much, and I yield back, Madam Chair.
Gentleman yields back. Let me take this opportunity again to thank all the witnesses for taking time out of their schedule to be here with us today. As we have heard today, our country's healthcare providers want nothing more than to provide their patients with the highest quality and clinically appropriate care. However, time and time again, delays in treatment are leading to adverse outcomes by taking doctors away from patient care. We need to improve the prior authorization process by streamlining and standardizing some of the procedures, while also making sure there is a clear understanding by doctors and patients of the items and services subject to prior authorization. I look forward to working with my colleagues on both sides of the aisle on this important issue. And believe me, this is a committee that works in a bipartisan way. So I will ask unanimous consent that members have 5 legislative days to submit statement and supporting materials for the record without objection, so ordered. And if there is no further business to come before the committee, we are adjourned. Thank you.
Great hearing.
Yeah.
Well done.
Isn't that cool?